I'm joined by Associate Professor Linda Selvey, a public health physician and infectious diseases epidemiologist from the University of Queensland, and Dr. Vyom Sharma, a GP from Melbourne. Welcome to you both.
Thank you.
I'll start with you, Dr. Sharma. As a GP on the front line, what sense do you make of what's happened this week, and how many patients are asking you about their eligibility? And of course, I'm asking you patients under the age of 40.
And I'm talking about the communication strategy about the vaccine, not the vaccine. The vaccine's a godsend. I'm just thankful that I'm not one of the GPs who's working at a clinic where we are rolling out the vaccine, because I can't imagine the kind of questions I'd get then. The questions that I have been getting, however, have been the same kind of questions that we've had about AstraZeneca, except they're just even more amped up. Questions about, is it safe? What does it mean? Am I restricted from getting it? And what does the language of the word preferred actually mean? At the end of the day, patients are hearing things from 5 different sources: politicians, CHOs, AMA, the College of GPs, what their friend says. And at a time where we actually need a really cohesive and comprehensive communication about AstraZeneca, we've got all these different voices saying slightly different things at the same time.
Okay, Professor Linda Selvey, I'll bring you in. We are looking for some clarity. Queensland's Chief Health Officer today said it would be awful if an 18-year-old died as a result of a blood clot from the vaccine, when a person of that age is unlikely to die if they actually experienced COVID itself. Can you explain the risk-benefit ratio to us for someone under the age of 40?
Yes, well, the risk of developing clots, according to the advice of somebody under 40 receiving the AstraZeneca vaccine, is about 3 in 100,000 or 1 in about 30,000. The risk of death, according to the literature that I could find in a high-income country such as ours, from getting COVID would be around, at that age, would be around 1 in 100,000. But not everybody who develops the clot will die. But I think it's also important to remember that even if we had no social distancing measures or any measures at all in place, not everybody would acquire COVID. So there's also that risk to take into account. So I think that's why ATAGI, the Australian Technical Advisory Group on Immunisation, recommended that it was preferred for people under the age of 40 not to receive the AstraZeneca vaccine. And in spite of the fact that we're now facing this outbreak of the this outbreak of the Delta variant, they haven't changed that advice.
Do you think the risk-benefit, though, could be changing on account of the outbreaks we're seeing around the country, or could it change if they worsen?
That may be, yes, potentially, but I think we'd have to be in a much worse situation than we are now. And because health authorities have been very quick to put us in lockdown and so on to try and control this virus, it is clear that the intent is to try and locally eliminate the strain in the same way that has been done with other outbreaks as well. I think the other thing that's worth noting is that particularly we know that a single dose of either Pfizer or AstraZeneca vaccine is minimally effective against the Delta strain. And also the AstraZeneca vaccine, even with 2 doses, is much less effective against the Delta strain than the Pfizer vaccine. And there's also this delay of at least 2 to 3 months before getting the second dose. So if somebody was to get the vaccine now, they're not going to be protected for at least 2 or maybe 3 months' time. So that's the other thing to consider in this equation.
Dr. Sharma, I'll go to you, and I understand that you're not vaccinating patients, but can you fill us in on the advice that GPs have received since the Prime Minister's late night announcement earlier this week on this issue? And do you think that GPs in the whole, are going to be quite enthusiastic about vaccinating the under 40s should they provide their informed consent?
Well, look, to put it bluntly, I contacted a couple of other GPs I know on social media asking, have you heard anything official since Scott Morrison made his announcement? So I think that should kind of tell you a lot. In terms of what information that we are going to kind of provide to patients, it's the kind of counselling I think we've done throughout. It's going to be talking about both the risks but also the benefits, and I think this is the part we're really kind of leaving out here. And sorry, just to lash on kind of to the professor's point about one dose not being effective. Well, the one dose may not be very effective against the Delta strain in terms of transmission and mild and moderate infection, but in terms of saving lives, it seems there is actually some decent efficacy. Now, I agree that maybe young people under the age of 40 are not benefiting from that strain enormously because their mortality rate from COVID is quite low. But I suppose what I'm trying to say is that this is the kind of complex discussions that we're trying to hold with patients under the age of 40, talking about the risks and benefits. And I think one of the problems with how CHO Jeanette Young kind of summed it up was I think it was a little bit kind of simplistic. I think, yes, on one hand, your chances of getting COVID and dying from it are low, but that's only for now. We don't know how long you will have to wait for Pfizer as an under 40-year-old. And we don't know if and when these outbreaks, we may kind of lose control because of this Delta variant. So, there are benefits that an under 40 person can have from getting AstraZeneca, that being that if they can potentially, if they get fully vaccinated, prevent transmission to other people in their families who perhaps do have a high likelihood of dying because of COVID if there is an outbreak. And some people just don't want to take the punt of waiting until they actually get access to Pfizer, not just eligible. So I guess my point is this: as a GP, I'm certainly not telling people under the age of 40 to rush out and get AstraZeneca, because I think some of the larger points that I think the professor was making earlier and CHO Young was making are still kind of valid. Yes, Pfizer is preferred, but it's not irrational at all if someone wants to go, I don't want to wait around, I want to keep my family safe, I'd rather take AstraZeneca now, knowing what the risks of TTS, this kind of clotting issue, are. And at the end of the day, they are not particularly drastic. The worst figures I can find anywhere in the world are 1 in 25,000 and a mortality rate that we're seeing in Australia for about 3%. Other countries have seen a greater one. But the point is that at the end of the day, the chance of dying from a clot is very rare, as is dying from COVID. And I think Jeanette Young really made a false equivalence there in saying that we don't want to see anyone die from a clot when they wouldn't die of COVID.
Professor Selvey, I'm really interested in getting your thoughts on essentially what is a change in the eligibility for the vaccine, which has been announced by the Prime Minister this week, and that the under 40s are being told that if they want to, that they can go to a GP with informed consent and get the AstraZeneca vaccine. Who do you think should be able to be vaccinated now? Who should we be prioritising to get the vaccine now, given what we know about the outbreaks, who's moving around in the community, who's working, just given the current situation, where does the priority lie?
I think the priority lies initially with people who are most at risk of getting infected and transmitting it to others. So, for example, quarantine workers, healthcare workers, aged care workers because of their working with vulnerable populations, those types of workers. And then the elderly and the most vulnerable who may not yet have been vaccinated. I understand that in Sydney, for example, there have been a number of hospitalisations due to COVID recently, and they're largely older people over 80 who've not yet been vaccinated. And I think for them, they should be priorities for the Pfizer vaccine, because we're not in a position where we can achieve sufficient numbers of the population to be vaccinated to protect us all at this point in time. And because of the time that it takes to get that second dose, particularly with AstraZeneca, that's too long a time to wait. So, given our limited Pfizer vaccine resources, I think we should be targeting them at those groups. And also because of that shorter time to ensure that they get immunity. I think I take on board some of Dr. Yong's points, but I think it's also important to remember that if you're not preventing symptomatic disease or low efficacy against that, then you're unlikely to also prevent transmission.
Just finally, and I know this might be a little unfair, but for both of you, if you could just give me a one-word answer, do you think it is fair for chief health officers and the premiers to be slanging it out in public on this issue?
Just one word, fair or not? Well, you know what? My one-word answer is yes, it's fair, because frankly, leadership needs to begin right from the top. I think the government's responsibility was to coordinate, bring all the stakeholders to the table, the CHOs, all of the cabinet, AMA, RSCGP, everyone needs to be on the board. I think it was their responsibility to kind of bring everyone together. The fact they didn't, well, that's when you see this play out very publicly.
It was good to have you explain that. Now I'll go to Professor Selvey.
Yes, I agree also that it's fair enough, particularly because they are following the advice of the experts, the Australian Technical Advisory Group on Immunisation.
Associate Professor Linda Selvey, great to speak to you. And GP Dr. Vyom Sharma, he has actually popped back. We lost your video for a second. Thank you so much to both of you for your time.
Thank you.